find this presentation helpful. I'm a psychiatrist. I'm currently doing a fellowship with Elise Robinson here at the Stanley Center. And I'm actually going to talk a little bit more broadly than just about schizophrenia. And there's so much confusion about what psychiatric diagnoses mean, what psychopathology is, that I thought I'd try to give a very broad overview, introduction to psychopathology aimed at being useful to non-clinical scientists. Sorry. Okay, so the topics I hope to cover, I don't know why that got cut off here. Well, anyway, I'm going to talk about Introduction to the Diagnostic and Statistical Manual in Psychiatry, which is the manual that covers psychiatric diagnostics. I want to give, before going on, give a brief description of the word or definition of the word nosology, because I may use it a couple of times. Basically, it's the branch of medical science dealing with the classification of illness. I want to introduce this concept of the perspectives approach to understanding psychopathology. It's essentially a way of organizing one's thoughts about different forms of psychopathology that I learned as a medical student and psychiatry resident, and I think could be quite helpful to basic scientists in formulating the most relevant biological questions about different types of psychiatric conditions. I'm going to discuss the term psychosis and describe two diagnostic categories, schizophrenia and bipolar disorder, in which psychotic symptoms are often prominent. And then I'm going to very briefly describe two approaches to attempt to organize psychiatric phenotypic data in a manner that is more conducive to biological research than the current nosological system, than the DSM. So what is the DSM? The DSM stands for Diagnostic and Statistical Manual. The 5th edition of this manual was published in 2013. It essentially lays out the objective criteria by which clinicians define different mental disorders. It's extremely long, and each revision is a result of years of meetings and studies to ensure that the diagnoses are reliable. Some people call it the Bible of psychiatry, though a more apt description would be to call it a field guide for psychiatrists. So what do I mean by that? And what are some of the problems with the DSM? So what I mean when I call the DSM a field guide is that it emphasizes diagnostic reliability rather than validity. So reliability just means that two clinicians who examine an individual for DSM diagnostic criteria will come up with the same diagnosis more often than not. That is different than biological validity, and that for most diagnoses, there's really no reason to think that they represent discrete, biologically homogeneous disease processes. As an illustration, consider what a doctor means when they diagnose a person with pneumonia. The symptoms of pneumonia include fever and a cough, but when a doctor says this patient has pneumonia, they're hopefully saying something more than just saying this person has a fever and a cough. They're putting forward a hypothesis that there is a bacterial or viral infiltration of the lung tissue leading to an inflammatory response, giving rise to a syndrome that includes fever and cough. By contrast, when a clinician says that a person meets DSM criteria for major depression, all they are saying is that they have had at least 5 out of 9 symptom criteria for at least 2 weeks. So they're not putting forward any sort of hypothesis necessarily about what caused their symptoms. Please don't take what I'm saying to mean that depression and other psychiatric diseases aren't real. They absolutely are. I just mean that there are likely to be many different ways that a person can end up meeting criteria for DSM, major depression, or other diagnostic categories. Another important thing to know about the DSM is that it serves multiple audiences, including clinicians, scientists, insurers, and in some cases, lawyers. What this means is that when using clinical data sets, people should just be generally aware that sometimes, the data in these sets can be, or the diagnostic categories may be intended to reach other audiences. And so there may be some reason why a marginal case, or where it's not quite clear what the appropriate diagnosis is, may be skewed in one direction or the other, for reasons that have nothing to do with science or nothing to do with clinical care, but maybe something to do with reimbursement or other considerations like that. So in a 2010 essay, Steve Hyman, who's a director of the Stanley Center, described a problem stemming from the DSM that he described as reification. And by that, he meant that even though the DSM categories are best understood as temporary placeholders until we're able to develop a nosology based on biological or other kind of rational distinctions, people often behave as if the DSM diagnoses are real things that exist in nature. And this can lead to a lot of confusion, especially for scientists attempting to learn about the true nature of mental illness. So just to summarize, the current state of psychiatric diagnostics is problematic from the standpoint of biological research because the conditions they describe do not represent biologically coherent or distinct natural entities. In some cases, such as with schizophrenia and bipolar disorder, which I'll talk about a bit, in a little bit, there's not likely to be a clear line separating the conditions. At the same time, many single categories, such as autism spectrum disorder, likely represent multiple distinct disease processes. In other cases, such as with intellectual disability, there is no clear qualitative difference between disease and health, meaning that to define someone as having an illness means creating essentially an arbitrary threshold. So I now want to share with you a way of thinking about psychiatric conditions that I learned about through medical training and that I think could also be useful to biologists who wish to study psychiatric illness. This approach is described in a book called The Perspectives of Psychiatry by Paul McHugh, the former chair of psychiatry at Johns Hopkins, and Philip Slavny. And it's basically a means of thinking coherently about the nature of different types of mental disorders. It's not a complete nosological system. It shouldn't be seen as an attempt to offer really an alternative to the DSM, but its central message is that not all problems that get someone to a psychiatrist or get somebody a psychiatric diagnosis are the same type of thing. So what do I mean by this? So the Perspectives approach identifies 4 types of problems that can get a person to a psychiatrist, or 4 perspectives which are useful in understanding various forms of mental illness. So the classic disease model, this is sort of the model that doctors and I think most biomedical scientists are most comfortable with. In this model, an etiology, a set of causes, leads to a specific pathologic lesion, to essentially a broken part, and that lesion gives rise to clinical signs and symptoms, which we call a syndrome. This works well for some, but not all forms of psychopathology. So for example, Alzheimer's dementia, there's a specific pathologic lesion that clearly gives rise to the clinical syndrome. And so the disease model works really well when talking about Alzheimer's disease. Some psychopathology is dimensional. And what I mean by that, like the example with intellectual disability, there may be quantitative, but rather than qualitative differences that distinguish between people with a problem and people without a problem. And there's evidence that that's maybe the most appropriate way to think about conditions such as ADHD. In some behavioral disorders, choices that individuals make that are intrinsic to the disorder cause brain changes that reinforce the pathology. So for example, the relationship between neuropathology and psychopathology in conditions such as addiction and anorexia nervosa is different in a subtle but important way than that relationship in conditions like dementia or schizophrenia. In certain other conditions, the narrative an individual tells himself, the life story, the way a person explains their circumstances, plays a role in driving the psychopathology. So for example, in some forms of PTSD, talking with a therapist and helping to re-script, to come up with a different narrative to explain what happened to a person can actually be a really important part of treatment. And it's hard to, in a model in which PTSD is entirely a biological phenomena, it's hard to explain how sitting down with a person and coming up with an alternative narrative of what happened could be useful. I want to make clear that I think that biological research can contribute to understanding each of these perspectives and not just the disease perspective. However, thinking critically about which perspective makes the most sense to look at a particular problem can help constrain hypotheses and can help constrain what makes sense to look for. Just a kind of simple example, I think it makes much more sense to search for disruptive de novo variants as causes of diseases rather than as contributing towards a predisposition towards engaging in a particular dysfunctional motivated behavior. Just to give kind of a flavor of how the perspectives approach might be of service to biologists, I think that depending on which approach you use, it does help constrain which particular questions might get asked. So if you're dealing with something that you're confident is a disease, you can ask, what is the etiology? What is the pathological lesion? How does the etiology cause the lesion? and how does a lesion cause the clinical syndrome. If you're dealing with something, that makes sense to view from the dimensional perspective, you might ask, what are the genetic and other factors that influence that trait in the general population, and what are the factors that would lead somebody to be on one extreme or the other of a particular trait? For behavioral problems, it makes a lot of sense, and it's really important to understand what makes certain stimuli, such as drugs, food, or in the case of anorexia, food restriction, rewarding to different people. What are the neurobiological correlates of craving that leads people to engage in behaviors that are getting them into trouble? Even the narrative or life story perspective, I think, increasing biological understanding can be really helpful. So what is the biology of the physiologic, that is the normal responses to adverse life events? Grief is clearly syndromic. There's clearly a biology underlying the grief response to a loss, and improving our understanding of that would be of great service. Similarly with, phobic avoidance after a traumatic event. What are the biological correlates to situations where these normal responses occur to a greater degree or persist longer than usual? So while biological research does play a role in understanding conditions from each of these perspectives, the disease perspective is the one most familiar to both physicians and scientists, and conditions that are best understood from the disease perspective are those where biological research probably has the best chance to offer a mostly complete understanding of the conditions. So just to reiterate, when we think about diseases, we can think about etiologies or causes that lead through a pathogenic process to a specific neurologic lesion, whether at the tissue, circuit, or cellular level, and that these pathologic disease entities lead through a pathophysiologic process to a set of signs and symptoms that we recognize as a syndrome. Each of these, etiology, pathogenesis, pathology, and pathophysiology, represents targets for scientific inquiry. So to give concrete examples of disease reasoning, dementia is a clinical syndrome characterized by irreversible cognitive decline. There are several known pathologies that give rise to dementia, including Alzheimer's disease and dementias associated with having multiple strokes. The specific pathophysiologic process by which, say, Alzheimer's pathology causes irreversible cognitive decline is not entirely understood, but certainly represents a tractable scientific problem. The etiologies of Alzheimer's and the processes by which the characteristic Alzheimer's lesions are caused are also not very well understood, but represent another important set of targets for scientific investigation. Schizophrenia and bipolar disorder are also clinical syndromes that are almost certainly caused by neuropathology. However, our current understanding of the nature of this pathology is well behind our understanding of Alzheimer's. As with Alzheimer's, we have very limited understanding of the etiologies of these illnesses, although genetic and other research has provided some hints that are beginning to lead to clear understandings of pathogenesis and pathology. So the two papers at the bottom of this slide, represent how identifying etiologic causes, in this case, identifying specific genetic risk factors for schizophrenia, can lead to knowledge about pathogenesis and pathology. The paper on the right was published about a year ago, and kind of following up on findings from genetic research, made a convincing case that the complement system is involved in synaptic pruning is overactive in at least some patients with schizophrenia. So that's an example of how learning about the etiology led to knowledge about pathogenesis and pathology. So the take-home point on the perspectives, the things that I'd like people listening to remember is that different psychiatric problems have different natures, and that careful consideration of the nature of the affliction one wishes to study is critical for framing the most relevant biological questions. Another point I'd like to just put into your minds is that psychopathology is not always reducible to neuropathology. So minds generated by intact, well-functioning brains can face terrible circumstances, find themselves in situations they're poorly equipped to handle, come to erroneous judgments, and make poor choices that lead to great suffering, to psychiatric diagnosis, and to a need for mental health treatment. So I want to switch gears a little bit and speak just briefly about some terms that often get thrown around when talking about psychiatric diseases, and that can be sources of confusion, especially to non-clinicians. So psychosis is a term used to refer to three types of psychiatric symptoms that often but not always occur together. There's a typo here: hallucinations are perceptions without a percept. That means Basically, the experience of having a true auditory hallucination is subjectively indistinguishable from actually hearing something through your ears, but there is nothing in the outside world that is generating that stimulus. A delusion is a false belief that is fixed. That is, it is not subject to rational consideration of evidence. It is also idiosyncratic, and that a belief that is, shared within an individual's cultural community, even if I thought it was false, it would be wrong to call that a delusion. Thought disorder refers to a lack of logical connection between thoughts. So it's important to realize that psychosis itself is just a set of symptoms. It's certainly not a single disease, and it's not even really a syndrome. Psychotic symptoms can occur as part of many different syndromes. For example, intoxication or withdrawal, delirium caused by an underlying medical illness, dementia, as well as so-called primary psychiatric disorders. So two such disorders are schizophrenia and bipolar disorder. As already discussed, these are clinical syndromes without clearly understood pathologies. They're characterized in part by lifelong vulnerability to developing psychotic symptoms. Emil Kraepelin was a 19th century psychiatrist who first articulated that these two broad classes of chronic psychotic illnesses may be distinct, and the distinctions he made, the descriptions of these two chronic psychotic illnesses are still more or less reflected in the DSM today. And their classic forms, schizophrenia and bipolar disorder, are often clearly distinguishable from each other. However, many individuals with chronic psychotic illnesses are not easily categorized as having one disease or the other, one syndrome or the other. So schizophrenia is characterized by a progressive course, meaning that in its most common form, once a person falls ill, they generally remain at least partially impaired for the rest of their lives. Psychotic symptoms in schizophrenia are, generally speaking, much more prominent than mood symptoms. That isn't to say that people with schizophrenia don't have pathologic mood symptoms, just that these psychotic symptoms, the hallucinations, delusions, and thought disorder, seem out of proportion to those mood symptoms. Schizophrenia is also characterized by deterioration in a person's personality and in subtle but still devastating forms in their cognitive abilities. Schizophrenia is a diagnosis of exclusion, so there's no single feature that a person can have that's what we would call pathognomonic, meaning that if a person has X, then they definitely have schizophrenia. There are actually many different combinations of signs and symptoms that a person can have to get diagnosed with schizophrenia, but it requires excluding other causes of their pathology. Schizophrenia generally does have a poor prognosis, but there are many exceptions. Ellen Sachs is one such exception. She's a woman with schizophrenia who's also a law professor at the University of Southern California. She's written extensively about her experiences and about legal and ethical issues pertaining to mental illness, and is a recipient of a MacArthur Genius Grant. And so I just want to make clear this is a very heterogeneous condition, and it's important to realize that when doing research, attempting to understand it. Bipolar disorder, by contrast, follows an episodic course, meaning that between episodes of acute illness, many individuals with bipolar disorder can return to basically functioning well. Psychotic symptoms in bipolar disorder usually emerge in the setting of other very prominent disturbances in mood. So people with bipolar disorder, what this means is that they're vulnerable to both depressions, which is characterized most prominently by pathologically low mood, and manias, characterized by pathologically elevated mood. Just to give a very kind of brief conceptual overview of what affective illness is, so mood disorders, what depression and mania are, these tend to be conditions in which there are simultaneous pathologic changes in mood, how a person just generally feels, their self-attitude, meaning how they think about themselves. So a depressed person may have very self-deprecating thoughts. Somebody, more towards the manic end may vastly overestimate their skills, abilities, or how they seem to other people, as well as energy. So a person with depression will, may often feel and appear very slowed down in their behavior and their speech. a person with mania will often appear quite sped up, both psychomotorically as well as in their speech, their thoughts. People with mania often have decreased need for sleep, so they will only sleep, a couple hours each night and still feel that they have lots and lots of energy. So really, to understand more about bipolar disorder, my recommendation is to look up Kay Jamison. So she's a woman with bipolar disorder. She's also a full professor of psychiatry at Johns Hopkins. She's written one of the best memoirs about this disease called An Unquiet Mind, and is also the co-author of the definitive scientific textbook on mood disorders. So her ability to excel personally and professionally after starting and sticking with treatment for her disease is illustrative, I think, of the hopeful prognosis associated even with very severe forms of episodic psychotic illness. So while these classic descriptions of schizophrenia and bipolar disorder are distinguishable, and kind of classic cases absolutely exist, the reality is that the boundaries between the disorders are fuzzy, and that many, many individuals have features of both. There is a diagnostic term, schizoaffective disorder, which basically means a person meets full criteria for both schizophrenia and bipolar disorder. However, nobody really thinks that schizoaffective disorder is a homogeneous class distinct from schizophrenia and distinct from bipolar disorder. But the fact that it is often used clinically reflects the need to classify individuals who really don't fit comfortably under either schizophrenia or bipolar disorder. Family and molecular genetic studies also show large genetic correlations, also suggest that the etiologies for these disorders are and probably the pathologic lesions are largely shared. So just to take one example, in the 2009 paper that first described polygenic risk scores, Purcell and others showed that polygenic risk for schizophrenia is also strongly associated with bipolar disorder, though not as strongly as for schizophrenia, suggesting that these diseases share many risk factors, but also probably have distinct etiologies and pathologies as well. So from a biological standpoint, there's really no reason to believe that the recognized syndromes that include chronic psychotic symptoms represent distinct pathologic disease entities. It seems likely that several different types of neuropathologies can give rise to schizophrenia, bipolar, and other psychotic illnesses. And some pathologies can probably cause either classic schizophrenia, classic bipolar, or phenotypes that lie somewhere in the middle. And so, while these are partially distinct, they're also greatly overlapping. And, this makes it a real challenge but also extremely important to work out the biology, the different biologies that can give rise to these devastating syndromes. So I want to conclude by briefly mentioning two initiatives that you might have heard about or that you will hear about that reflect efforts to identify more homogeneous populations for biological research. So RDoC is a framework developed by NIMH. It's intended to spur research in psychopathology that cuts across DSM categories. Basically, they developed, created a matrix that identified many domains and constructs chosen specifically to reflect contemporary knowledge of major systems of cognition, motivation, and social behavior. So this doesn't represent an alternative nosology that is, ready for clinical use, but it identifies certain phenotypic features that may kind of adhere together, that may be useful in identifying more biologically homogeneous groups than DSM categories. Another effort that I'm involved in is the Stanley Center Phenotyping Project. This is an endeavor to use the existing psychiatric genetic evidence base in order to create a brief instrument or sets of instruments for prospective use in large-scale studies of psychiatric genetics. So our goal is to collect phenotypic information that is likely to be highest yield from the standpoint of psychiatric genetic discovery and interpretation. This endeavor is currently in very early stages. So I want to conclude just by reinforcing psychiatric diagnoses don't represent biologically homogeneous phenomena. It's important to consider the type or the perspective, the most relevant perspective of for the psychiatric phenomena that one wishes to study when considering how to formulate the most relevant biological questions. Schizophrenia and bipolar disorder are both chronic psychotic illnesses, and however, biologically, they're not likely to reflect entirely distinct entities. Improved nosology, improved ability to identify homogeneous populations will certainly spur scientific progress. At the same time, in order to create improved nosologies, we need to learn more about the underlying biology. And so this is sort of a chicken-egg problem that we should all generally be aware of. So I want to thank my PI, Elise Robinson. I want to thank Dennis for inviting me to speak here, as well as Steve Hyman, Paul McHugh, and Philip Slavny. Please, if you're watching this or come across it on YouTube and you have any questions or comments for me, I'd love to hear them. Thank you.
Thank you.
Yeah.
Thanks everyone. I think we have time for 5 minutes for questions. Feel free to ask Jacob.
All right.
Okay. We're also a little bit late.
Okay. Any questions?
I have too many questions. Maybe. Thanks for the talk. There must be. How standardized are the testing batteries for all of these things? I mean, I'm sure there must be a lot of tests that have been proposed to classify this or that aspect of where things. And I know the epilepsy field a bit, but I'm a researcher, so next to nothing about the stuff that you present.
No, I mean, there are a number of testing batteries or standardized ways of trying to assess the presence of psychopathology. There are kind of long, kind of full scales or schedules developed to adhere very closely to DSM diagnoses that can be administered by a clinician. And again, the end result of using these batteries is that you will get generally reliable information. And that if by reliable meaning that if the answers, the diagnoses you get really shouldn't be dependent too much on which clinician happened to be interviewing this patient, which day the patient happened to be interviewed. So the standard instruments are good from a reliability standpoint, but that still doesn't fully address the problem of, are the things that they're measuring valid, distinct entities? And so there are reasonably good instruments, but they don't kind of, the results are only as good as the categories they're attempting to measure.
Okay. All right. Okay. Great. Thank you. Thanks everyone. I wish everyone a nice weekend, and we talk next week. Okay. Bye-bye.